Welcome to Pulmonology. This is the branch of clinical technology that focuses on the respiratory system. We use different tests and procedures to diagnose different lung diseases, give therapy for those diseases, and also assess if the therapy we are giving is beneficial for the patients that we see. There are many different tests that we do, so I'm just going to go right into it. The first and most common test that we do is spirometry. So this is a really fast and easy test that we can do to assess the lung function of smaller and larger airways in the lungs. There are two different types of spirometry that we can do. There's slow vital capacity and forced vital capacity. Slow vital capacity is very relaxed breathing, just in and out, and then exhaling and emptying your lungs, and then inhaling and filling your lungs, but very slowly, very calm, very relaxed. Forced vital capacity, however, is very forceful, and it involves blowing out really hard and really fast, as well as really quick inhalation, and it requires that you push as much air out of your lungs as possible for about 6 seconds. So for spirometry, we will generally use these portable spirometers because they're just easier to use. They're smaller and you can take them with you to the wards if you have to do a patient that can't walk. We also have bigger machines that you can also do spirometry on. Basically, the patient will blow into and inhale from the machine, which will give you a graph or a flow volume loop, which is seen here. And then the appearance of the loop, as well as the table of results, can be used to assess the lung function and also to diagnose possible airway disease, either obstructive or restrictive. In some cases, we will give the patient a bronchodilator after they do the test and then have them wait for 15 minutes and repeat the test. So a bronchodilator is basically like asthma medication. It's a pump that they will take, and then we will assess their airway function afterwards to see if there's any difference. Most of the time, patients that have obstructive diseases will have a positive difference in their post values, so after they take the bronchodilator, because the medication helped to open up their airways and improve their lung functions. So we will do the test 3 times to try and get at least 3 good blows. Otherwise, we can do it up to 8 times, but no more than that. There are many different things you have to look at while you're busy doing the test. The patient might start getting tired. Some patients will have asthma attacks. It's common for things like that to happen because we're working with patients who have lung problems. Their lungs are already not at the greatest health they could be. So sometimes we do have emergencies, so you need to be ready for that. You must always ensure that you're wearing an N95 mask, especially now during COVID, because this test is aerosol generating and safety is very, very important. So the results of a flow volume loop test, besides the table of results that you'll see, where you'll be able to see the forced vital capacity, as well as your FEV1, which is your forced expiratory volume in 1 second. So there's a lot of different values that you will get from that. But in asthma and emphysema or obstructive diseases, there'll generally be a curvature towards the end of the top section of a flow loop because it takes them longer to exhale all of the air that's in their lungs, but it doesn't come out as forcefully as it would with a healthy patient. And then with the restriction, it just looks like a smaller version of the healthy flow loop, which is the dotted line. So now we'll move on to lung volumes. There are many different ways to go about measuring lung volumes, including dilutional methods such as helium and nitrogen, which involves the inhalation of the gas and the collection of it afterwards, which will then determine your functional residual capacity. And we can also use body plethysmography, or the body box, which is the pictures that you see. Basically, the patient will get into the box, sit down, and then they will have to breathe in and out first at a normal pace. Then they will be asked to breathe faster, and then a shutter will close, which will block airflow, but they will have to continue breathing fast. And once the shutter opens again, they will then do a flow volume loop like the one for spirometry, and then the test will be finished and the door will be opened. So this is done at least 3 times as well. We want to get 3 good efforts, and it can measure the lung volumes and capacities, as well as airway resistance and airway conductance. So this test can be used to differentiate between different obstructive diseases and different restrictive diseases, and it can also be used to stage chronic obstructive pulmonary disease, or COPD. So staging COPD is basically a way of showing on paper how impaired the lungs are at that stage in their COPD. So stage 1 is not as bad as stage 4. So it involves the breathing at different rates with the door closed, like I said, and then after doing the test, we can give a bronchodilator as well, wait 15 minutes, and then repeat the test again, just as with flow volume loop, to see if there's any difference in the results. Now we move on to diffusion. Diffusion uses gases, or carbon monoxide generally, to check that there is appropriate gas exchange in the lungs between oxygen and carbon dioxide. So it assesses how well your lungs undergo gas exchange, basically. So what happens is that the patient will inhale the carbon monoxide, the gas, and hold their breath for 10 seconds. Then they will exhale the gas, and it will be collected and then analyzed. So then it will be able to show how much carbon monoxide is left in the gas after it's already been in the lungs undergoing gas exchange for 10 seconds. So this will then ensure that gas exchange is occurring appropriately. It needs to be about 80% or more for it to be normal. Restrictive diseases tend to decrease diffusion capacity, so things like fibrosis or pulmonary edema as well will result in a decreased diffusing capacity. Next, we'll move on to blood gases. So we can use blood gases for diffusion as well as long-term domiciliary oxygen therapy analysis, or LTDOT. For diffusion, we will draw an arterial blood sample from the radial artery to check for the levels of carbon monoxide in the blood, as well as the hemoglobin levels in the blood, which we then use to input into the computer, and it will ensure that we get accurate readings for diffusing capacity, because it will help the computer assess how much hemoglobin is in the patient's blood and how much carbon monoxide was already in their blood before we did the diffusion test. So we will also use it for LTDOT to see if a patient qualifies for oxygen. We will use it to check the partial pressures of carbon dioxide and oxygen in their blood, as well as the levels of carbon monoxide and oxygen saturation. Carbon monoxide levels are important because patients aren't allowed to smoke while they are on oxygen therapy, because it's a fire hazard, but also it takes away from binding sites for oxygen when carbon monoxide is in the blood, as the carbon monoxide has a higher affinity for hemoglobin than oxygen does. So what will happen is that we will then draw blood from the patient when they are off oxygen and analyze it in the blood gas machine. We will then put them on oxygen, and once they've reached an acceptable saturation on the pulse oximeter, we will then take another sample and use the blood gas machine to analyze it again, just to prove the results that we have. And then we will decide whether or not a patient qualifies for oxygen, how many liters they should get, and for how many hours a day they should use it. Now we'll move on to respiratory muscle function testing. So for this, we have maximal voluntary ventilation, or MVV, and maximal inspiratory and expiratory pressure, or MIP and MEP. MVV is hyperventilating for 12 seconds, basically. We use the spirometry machine, and a patient will hyperventilate for 12 seconds. It can make you very, very dizzy, so a patient must be warned about this beforehand, and it is used to assess the function of the muscles during hyperventilation. And you can also tell then if a patient desaturates during hyperventilation if you put a pulse oximeter on their finger while they do this. It shouldn't be done more than 1 or 2 times, because it's very, very difficult to not faint if you're running out of oxygen or hyperventilating like that. And it is not something we do that often. We tend to do MIP and MEP more often. So MIP and MEP, we will calculate reference values according to the equations given for men, women, boys, and girls. And there are equations that are given for those for men, women, boys, and girls. And then we will use the equation to calculate what their MIP should be and what their MEP should be. We will then do the MIP and the MEP. So with MIP, We will ask a person to exhale and empty their lungs. They will then put the device you see in the right picture in their mouth and inhale and try and inhale, but no flow will come through. There's no air coming in or out of the device. It's a closed system. So they'll inhale and the dial will move to give you a value, and then we will use that to calculate the percentage of the predicted value that they managed to get. For MEP, they will be asked to fill their lungs, inhale, and then to blow out into the device. But obviously, again, no air will be able to flow and the dial will turn to give us a value. So we will have to do each one of these 5 times, and we choose the 3 highest values, and then we will measure how much the percentage that they managed to get of their predicted values. And that will show you how well their diaphragm is working, how well their lung muscles are working as well. So it's a very good test to have done, especially if there's diaphragmatic weakness. Then we'll move on to bronchoprovocation challenge testing. So there are many different tests to do this. This is a way of assessing if a person has asthma or hyperreactive airways. Sometimes you can't see if a person has hyperreactive airways with lung volumes or with spirometry, and in those cases, if we still suspect that they do have hyperreactive airways, we can do bronchoprovocation challenge testing. So there are a few different ones. There's the skin prick test, which we will get into in a minute. The methacholine challenge involves the inhalation of methacholine, which is a chemical that can cause bronchoconstriction. Basically, a patient will do a flow loop, like for spirometry, a baseline flow loop, and then they will be asked to inhale increasing doses of methacholine. After each dose, they will be asked to do another flow loop after waiting a certain amount of time. And if the certain parameters of the flow loop decreases by 20%, then the test is considered to be positive. So this can assess how reactive your airways are depending on how high the dose was that caused a reaction. So if there was a lower dose that caused a reaction, then your airways are more hyperreactive compared to someone who had a positive reaction on a much higher dose. Then we also have the histamine and the mannitol challenge, which are very similar to methacholine, except we are using histamine and mannitol instead as the inhaled chemicals. Then we have exercise-induced bronchospasm testing. This basically tests for exercise-induced asthma, if you want to call it that. It checks to see if you'll have bronchospasms during exercise, which can occur with a lot of people. They might not be affected by their asthma, except when they're exercising. So how it will work is that we will do an ECG and a flow loop as a baseline, and the patient will remain on the ECG, and then they will be asked to run on a treadmill or cycle on a cycle ergometer or a bicycle, basically, for a certain amount of time until they reach their maximum heart rate, which we will calculate using an equation. After they reach their maximum heart rate, they will then be taken off exercise and asked to sit down. We will then do a flow loop again and wait 5 minutes, do another flow loop and wait another 5 minutes, and we will repeat this until their values either increase to the same that they were at the baseline, or they decrease to a dangerous point and we have to give them a bronchodilator because they are having a bronchospasm. Some patients do not have any reaction, and in that case, they do not have exercise-induced bronchospasm. Some patients will react very quickly and they need to be taken off the treadmill before we can even finish the allotted time that they should have stayed on the treadmill. Then we also have eucapnic voluntary hyperventilation. This is basically to see if a person will have a bronchospasm during ventilation. Sometimes hyperventilation can cause bronchospasms. So hyperventilation will occur, and then a flow volume loop will be done at 5-minute intervals until either the baseline returns to what it was before the test, or we have to give them a bronchodilator to prevent them from having a bronchospasm. So the skin prick test is what I was speaking about before. It involves the pricking of liquid into the top layer of the skin. So we will use different liquids that are allergens, basically, but they are inhaled allergens. So there are substances that we can inhale which can cause bronchospasm when they reach our lungs. So we will have a positive control, which is histamine, which is what can cause allergic reactions. So the patient should have a reaction to the histamine, and then a negative control, which is saline, which a patient should not have a reaction to. The other liquids include things such as dog hair, cat hair, feathers, dust mites, plain dust, molds. There's many different substances that you can use. These substances will be dropped onto the skin of the arm in little droplets, and then they will be pricked into the skin. The patient will wait for 15 minutes, and then the reaction will be measured. The wheal is the raised bump or the white section, and the flare is the redness around the bump, both of which will be measured. Basically, how it works is that if a reaction has a wheal and a flare bigger than the histamine or the positive control's wheal and flare, then we can say that a patient is allergic to that. And if they do have a reaction, but it's smaller than the positive controls, then we can say that they are sensitive to that substance. So in this next picture, I had pricked myself with histamine just to show you a certain reaction. It's a little bit difficult to see, but the raised white section is the wheal and the flare is the redness around it, which I will now circle. This is the reaction I had after 15 minutes of pricking myself with histamine. That is the wheal right there, you can see, and the flare goes all the way around there. So we will now measure this from end to end, and my wheal and flare came out to 7 millimeters and 42 millimeters. So if I had pricked myself with another liquid and the wheal and flare of the reaction of that liquid was bigger than this, then I could say I was allergic to that liquid. Next, we will move on to cardiopulmonary exercise testing. We have some field tests that we do with this that we'll get into in a moment, but generally we use a treadmill or a cycle ergometer, or for paraplegics, we also have an arm ergometer, which is like a cycle, but for your arms. A patient will be hooked up to a 12-lead ECG. They will also have a mouthpiece, which will measure their ventilation. They will also have a blood pressure cuff on their arm, and then they will be asked to exercise for a certain amount of time. There's a lot that goes into this. We need to calculate if they must do it incrementally or if they should just do it at a steady state, which means we give them an increased workload, or they just work on one workload for the entire test. They need to reach their maximum heart rate, which we will calculate with an equation, which is 220 minus the age of the patient. That's the maximum heart rate they should reach. So if they get to 80% of that heart rate or above, then we can stop the test and say that we've reached the maximum heart rate, so the test can be stopped. This is also where we work with cardiology healthcare workers, because we do require them to be there to keep their eyes on the ECG, but we do also need to know how to evaluate an ECG, because there are certain things that stop a test from that we need to stop a test from carrying on if they occur. So we need to know if a certain block occurs, then we have to stop the test. We need to be able to tell when is the right time to stop the test and when not to stop the test. So it's actually very interesting to be able to work with people from other specialities and not just with pulmonary techs. So we will do that for a cardiopulmonary exercise testing to measure exercise intolerance. Some people desaturate during exercise. Some people have heart problems during exercise. So that's the point of that test. It assesses the whole cardiopulmonary system during exercise. Then we will have field tests that we do basically generally for screening before surgery, just to make sure that a patient is strong enough to go through surgery. And the most common of that is the 6-minute walk test. Then we also have the incremental shuttle walk test and the endurance shuttle walk test, which requires requires 2 cones that you walk in between, slowly increasing the speed at which you're walking. With the incremental shuttle walk test, and with the endurance, you don't increase your speed. You just walk at a normal pace until you start to tire out. But the most common test that we do will be the 6-minute walk test. We will calculate the reference distance, so the distance you should be able to walk using reference calculations that we are given for men and women, and also your age is involved, as well as your height, your weight. So we will calculate the distance you should be able to walk. You will then be asked the Borg scale, which is a scale from 1 to 10 that's supposed to analyze your dyspnea and your level of fatigue before walking for the 6 minutes and also afterwards. So we'll ask the patient on a scale from 1 to 10, how tired are you? How out of breath are you? 1 being not so tired, not so out of breath, and 10 being extremely tired or extremely out of breath. And then they can tell us how they are feeling personally. We'll then put the pulse oximeter on their finger to measure their heart rates and keep an eye on their saturation, and they will be asked to walk as fast as they can for 6 minutes. The distance that they walk will then be calculated afterwards, and the percentage of the predicted distance that they manage to walk can then also be calculated to tell us how far they managed to walk from what they should have been able to walk. This is also a good way to see if patients desaturate during exercise. So we do need to keep an eye on the pulse oximeter, because it has happened before that we need to stop testing because a patient's saturation has dropped below 80. And it is very important that we are very vigilant during this test, because accidents can happen. So that will normally be used as surgery screening. This and spirometry is normally used for screening for surgery. Then we will move on to bronchoscopy. This is one of my favorite parts of pulmonology, because we get to go into theater and we also get to be a part of the procedure. So a patient will be under anesthesia, they'll be fully under, and a camera at the end of the bronchoscope will be introduced into their airways to look for anything irregular, such as blood, lesions, inflammation, mucus, pus, growths, etc. So we can also do biopsies, which involves the use of forceps to pull a piece of the tissue from the internal wall. We can use lavages, which involves the introduction of saline into the lungs, and then we suction that saline out into a container. And we can also do brushings, which is a little brush on the side, on the wall of the airways, which we will then put onto a microscope slide. And that can be sent to cytology or histology for examination. We can diagnose lung diseases, we can diagnose cancers. It's actually a very, very interesting part of pulmonology. So the clinical technologists do not actually do the bronchoscope, but we are responsible for the equipment. We need to make sure that it is clean, that we undertake proper infection control, that it's working properly. We are also responsible for assisting the pulmonologist who is doing the bronchoscope. So we will have to help them with brushings, with biopsies, and also with the lavages. We will sometimes be the ones who inject the saline. We need to make sure the tube is attached. It's very hands-on. And we are also responsible for ensuring that the samples we take during a bronchoscopy get to the lab. And finally, another part of pulmonology is sleep studies. So here we work very hand in hand with neurophysiology, because they also do sleep studies. And we will do sleep studies to diagnose sleep apnea, which is the cessation of breathing during sleeping. So this test can be done either at home or at a lab, where the heart, the brain, and breathing will be monitored while a patient is sleeping to diagnose whether or not they have sleep apnea and need a CPAP machine or a CPAP machine, which forces lung air into your lungs when you stop breathing during sleeping. Thank you very much for listening, and I hope that I've managed to convince you or more of you to join pulmonology. It's very interesting. We work with a lot of different people, and it would be really great to see more people interested in it. It's a very demanding job, but all jobs are. And it's just so much fun to be able to do so much different stuff and just not just focus on the lungs constantly, being able to do the skin prick tests and being able to draw arterial samples and being able to help people in general. It's just a great part of clinical technology. It's just a really great place to be. So thank you all for listening. And hopefully there are some videos uploaded along with this for you to see. There will be a video of spirometry, a video of MIP and MEP, as well as a video of a skin prick test that I've also done, and also a short video on how we would draw blood, but without the actual drawing of the blood. So thank you very much for listening, and have a great day.